where I live, it's a fairly rural area. One of the issues that has been raised about that is that where in the villages you quite often get a majority of, or at least a higher number of older people, often with the chronic and older people's illnesses that you get, or conditions, needing more treatment, more costly interventions. If the system said, hey, people can go off and register where they work, and it's different, and it would be generally different, then you might get quite a large number of people going off and registering in the nearby city or town, leaving the rural practice depleted of those people, with even greater proportion of the more costly patients, which might make that practice unviable, which might make that practice close, which might then totally deplete the choice for the people left behind.
I think it's about continuity of care and the fact that the health service doesn't have the IT in place to be able to cope with people living in one place and having GP surgery somewhere else.
I think that could be a real issue, actually. If you've got all your records in one place, you want to see a GP in another place, what happens there with picking up on quite pertinent health issues? There could be a whole range of issues coming up there, so you'd have to be very careful about that.
What I personally favour is where someone really requires to see a doctor at intervals where they work, they should have a kind of work type registration in that area, but maintain the family practice for home and the rest of the family. Because let's face it, if you're at home, you're at home on the whole more time than you are at work, unless you're a workaholic. You're also, if you're sick, likely to be at home rather than at work generally. And what we're talking about here is kind of regular stuff. We're not talking emergencies. That's got another system for dealing with that, A&E and out of hours type stuff. That's something else. But when you're talking about regular seeing of someone, then you're really talking about very, very rarely at work, maybe once every couple of weeks if you have a condition that needs that. And the rest of the time you'll want your family doctor. So I'd like to see a dual registration system where the main one is still there, and perhaps a little bit of that money will go to the work practice. And they should be jolly well in communication and lots of jolly good IT to make sure that happens.
The first challenge that is normally cited when people first hear about this programme is that of home visits. It is an issue for people living a long way from a practice they choose to be registered with, but it's certainly not an insurmountable issue. It can be resolved, and there are 4 different options out for consultation with the public as we speak. Other issues surround funding, access to community services, prescribing, IT, but again, whilst these are issues, I believe they all have solutions, and we can deliver by solving these issues.
If you've got a patient who is going to suffer from cancer or something and needing home visiting, you actually split up all the continuity of care that would normally occur in one practice. District nurses, Macmillan nurses and so on. You split them up into different areas, and then you're going to actually end up with care that is much, much worse, fragmented compared to the current situation. And continuity of care has been shown when it's the same clinicians dealing with patients over a long period of time. It's been shown to actually be very cost effective, and I think that's a message that the government needs to hear in the current climate of trying to cut costs. That cost effectiveness is the most important aspect they're going to want to know about. But the patients who go and see the same doctor actually end up taking tablets rather than not taking tablets. They take their advice, they get referred less, the overall costs are less, the drug costs are less, and actually they turn out healthier in the end. So I think it's a really important message that we don't lose continuity of care for our patients, really.
Currently, one of the problems we have in general practice is that we are frowned upon enormously if we close our list. And yet if we had this situation where I might find that suddenly, for whatever reason, everyone thinks that I'm the best thing since sliced bread, and I get 500 more people adding onto my list from anywhere in the country, well, how do I deal with that? How do I cope with that? And a school couldn't cope with that. We're in a unitary authority here. Why can't someone who lives in Hampshire say, actually, I quite like Newbury Unitary Authority, I'm going to pay my rates to them and get all their, it wouldn't work. Boundaries are something we have there because they actually help contain and develop services. And I think we mustn't forget that. I think primary care is in exactly the same place as many other systems that require boundaries.